our so we have people here live in the audience, and we have many of you watching from home. We will be recording it as well. So hopefully all this technology works well. Those of you at home, you can still ask your questions. You can just type them into the Q&A box, and we will monitor that throughout the presentation. And then if there's time at the end for our speaker to answer additional questions, we will read those out to him. So I will now introduce our speaker so we can get started today. The topic is Alzheimer's disease, advances in diagnosis and treatment. And our presenter today is Dr. Lanyard Dial. In 1986, Dr. Dial became the medical director of Livingston Visiting Nurse Association and established Ventura County's first Medicare certified hospice. Dr. Dial continues to serve as Livingston's medical director. He received his medical degree from Washington University School of Medicine. His academic honors include the election to Phi Beta Kappa and Alpha Omega Alpha societies. He is a diplomat with the American Board of Family Practice and holds certificates of added qualifications in both geriatric medicine and hospice and palliative medicine. His faculty appointment is as a UCLA Associate Professor of Family Medicine. And those of you that have heard him before know he's a fabulous speaker, and we're so fortunate to have him with us today. So thank you, Dr. Dial.
I'm excited to try the new hybrid system. This is the microphone for them to be able to hear well. And what I've been told is to try to stay in the boundaries of the picture here. So I'll try to do that. Thank you all so much for attending and for watching online. My intention today is to give you the newest information about diagnosis and treatment of Alzheimer's disease. Now, I trained in geriatrics at UCLA in 1985. And so I've been a geriatric physician for 41 years. And I have never seen what I'm going to tell you today in the last 40 years. What we have been able to do in medicine, in the management, in the diagnosis, and the treatment of Alzheimer's has been exceptionally limited. But the last several years, the genie is coming out of the bottle, and it's really exciting at this time to kind of see and understand that. This talk is a little complicated. There's a lot of medicine to understand. I'll tell you my last slide so that you get the bottom line to this. There are now X-rays and blood tests that can confirm a diagnosis of Alzheimer's in an individual. With those X-rays and blood tests having been completed, people can become eligible to get an IV infusion of medicine that can hopefully stop the progression of this disease. So that is amazing. And the devil of all of that is in the details. So we're going to spend the next hour. I'm going to try to help you understand some very complex medicine. I'll try, and I've done my best to make it friendly to audiences, I hope. But please, along the way, stop me if you have questions. I'm going to move a little bit so that you guys can see the slides behind me and try to stay in frame. And they're going to have the slides directed to you. I'm good. I'm still on there. Okay. No, I'm good. So we're going to look at clinical features of mild cognitive impairment. And it's important you understand that language. That's now an official medical diagnosis. And it's important because both the diagnosis and treatment is best done with an individual in that state, and Alzheimer's disease itself. I'm going to teach you about a protein in the body called amyloid and a separate protein called tau. And those two proteins are crucial to understand Alzheimer's disease and where I'm going today. We're going to back up here. We're going to summarize the role of the imaging, the X-ray tests, and when you're eligible and how it works and all of that. and the blood test. The biochemical markers is the medical language for that, and I'll go through that. And then I'm going to explain the infusion treatments that are available for this. To understand that and the difference between mild cognitive impairment and Alzheimer's disease, you have to understand activities of daily living, functional ways we describe how a person's doing. So this is a mnemonic that was developed in the Mayo Clinic, and I use it because if you can't do these things, you're near death. So the mnemonic is dressing, eating, ambulating, toileting, and hygiene. So can you dress yourself? These are describing an individual's function. Can you eat, get food in your mouth? Can you ambulate, move about, walk? Can you do your toileting, get to the bathroom yourself, wipe yourself, keep yourself clean? And can you do your hygiene, take your own baths? That is basic ADLs. And we rank them in a scale of 1, 2, and 3, where 1 is you can do this. Totally independent of anybody helping you, you can still do this. And I would be willing to bet that the vast majority of you who are here, because you're here, are capable of doing all of these independently yourself. Number 3, not 2, I'm going to do 3. 1, totally independent. 3, totally dependent. You cannot do these. Somebody has to feed you, dress you, help you with your toileting, help you get around, and help you be able to do your own bathing or showering. So you're either totally independent, 3, totally dependent, or 2, somewhere in the middle. Sometimes, or some of these you can do or can't do. So understanding when I talk along the way here about ADLs, you now know what I'm talking about. These are the ADLs. So normal aging people, you all, me, have a slow, steady, over years decline in our cognitive function. We lose about 10% of our neurons over our lifetime. So over 100 years, you lose about 10%. And what you will notice as you age is you forget a few things. You can't remember quite the name of that actor, or you don't remember where you put your car keys, but you're able to pull those memories back, and the loss that you experience does not at all affect your ability to do your ADLs. You have losses that you don't remember whether your car in the parking lot at Costco was down that first aisle or the second or the third, and you start down one and then you realize it's over on the next one. Happens to every one of us. That is the green lines of normal aging loss related to time of getting older. But people who are going to get dementia have a process where it goes along and then it gets mild, moderate, severe as their functional ability of their brain gets worse and worse. There is an illness process where you get a preclinical stage, a stage where on occasion the patient may know something isn't right, particularly people of high intellect when they spent a lot of their life doing a lot of complex tasks, and now they notice they can't do that quite right. It's a silent phase. You're still capable of doing all your ADLs, but we put something in the middle called mild cognitive impairment, where the changes are of concern to the family now, not just the person. That one or more areas of cognitive function is impaired, you still have capable of doing your ADLs. Not everybody who gets mild cognitive impairment goes on to develop dementia. Okay, there is some of the people with mild cognitive impairment, that's the lighter blue line, continue at a certain level. They don't all drop off. In fact, it's probably somewhere around a third to 50% will go on to develop dementia. So half or a little less than half. And the dementia is where cognitive impairment is severe enough that you start to lose your ability to do your ADLs. Okay, that's the difference. So a third of people with mild cognitive impairment go on to develop Alzheimer's in the next 5 years. That's from the Alzheimer's Association. So not everybody who has mild cognitive impairment is going to go ahead and develop dementia. The real question is, when do you cross the line? When do you start to say there's something more wrong than just mild cognitive impairment? And as I've said, that's when you need help doing activities of daily living. A quick and easy way to do this is here. You lose the ability to do your ADLs, which I just talked about, but would you feel like the person you're concerned about could stay at home on the weekend by themselves and you're gone? If you believe that the person you love can be left alone for a weekend, then they don't have dementia. They may still have mild cognitive impairment. Because again, it's the focus of the ADLs that they can't get to the bathroom by themselves. They can't prepare their own meals. They can't safely manage their hygiene or their toileting. Okay, so let's define this concept of dementia. It's a syndrome. It's loss of certain functions which are all together. This is like saying you're in Texas. Well, okay, but where? What specific part am I in? So you have dementia. Your brain isn't working right. You don't have a good memory for things. You lose some ability to do math problems. You lose some ability to do spelling problems. You have loss of some visual spatial pieces. So you have a group of symptoms, but it's not a specific thing. Loss of memory, other intellectual functions, calculations, problem solving. Some people have some change of mood and behavior. That's not uncommon. And it's rarely reversible. It's not something you could fix. What we're talking about today is a potential treatment for it that could stop it. It's not going to reverse it. It can stop it. That's the key. When you talk about the language of dementia, not a disease, describes the symptoms of the loss of memory and calculation that I just did, there are more than 100 different causes of that. One of those causes, and the biggest one, is Alzheimer's, and that's the one we're talking about today, because the biochemical markers, the X-rays, the treatment is only available for people with Alzheimer's disease. It's not for people whose dementia is due to strokes. It's not for people who have Parkinson's-associated Lewy body disease, and it's not for people with all the other types of dementia. This, if you will, the fourth most common here is what I've listed as frontal temporal Pick's disease. It's illness that affects the frontal lobe and makes people change in their behavior earlier than people who have Alzheimer's. So we're going to talk today only about Alzheimer's dementia. That's the only thing we have available diagnosis and treatment for. Okay, there we go. This brain thing is amazingly complex. The brain is made up of neuron cells that connect via axons and dendrites to other cells. The activity of that connection is electrical and chemical. For you to be able to hear me, your brain has to be able to not only go through the ear in, but conduct electrical impulses and release chemicals so that you can hear and separate out the words I'm saying. So it's a very brain function complex system. This is the neuron, its dendrites and its axons, and this is the pathology that happens for people with Alzheimer's disease. A protein called amyloid, which is normally around, but in people who have Alzheimer's disease, we don't know why, but the amyloid starts to get broken down and develop toxic pieces to it, and that toxic pieces destroy the dendrites and the axons of your neurons. So the amyloid protein is destroying your neurons. Inside those dendrites and axons, there is a framework, much like a radio tower built. And inside the dendrites and axons, that radio tower that is built along to hold it open and allow it to conduct information is made up of tau proteins. So the amyloid is destroying the axons and dendrites. Tau protein is released into your brain because of that destruction. So the two key protein chemicals that we're going to talk more about, amyloid and tau. Tau is T-A-U. That destruction in a microscope of a person who's died, who you can cut pieces of brain up, looks like that. You get a plaque of amyloid that's killed off the neurons. So beta amyloid destroys neurons and neuron connections. Obviously, there are chemical things happening because of that destruction. Your neurons and dendrites communicate electrically and they communicate with chemicals. So when those destructions happen by the amyloid, your chemical balance of what's going on in your brain isn't right. Okay? In fact, for the last 30 years, our treatment looking at Alzheimer's has been to try to replace those chemicals because you don't have them. Our new treatment is designed to destroy amyloid. So if you can destroy amyloid, you can stop this whole process from happening. So this is a normal brain. The process by which amyloid starts to destroy your neurons, again, we don't know why it's doing it. We don't have yet the key understanding of what makes this amyloid now become more toxic and chew up your dendrites and your axon. Don't know that. But it starts, and we know where it starts, kind of in the temporal and down parietal lobes here, like that. That's early where the Alzheimer's disease plaques of amyloid are found. And then they progress. Once you're down this far, no treatment is going to help you. You've got to stop that amyloid from destroying your neurons early in this process. So let's talk about making the diagnosis and what's new. Two things. We have now developed specific scans that can look at amyloid and tau protein in your brain. Those scans are called PET scans. So you may be familiar with the PET language. We've had PET scans available for a number of years. We use them primarily to figure out if people have cancers that have spread or have specific kinds of infections that are spreading, because the PET scan, which stands for positron emission tomography, is a radiation-built chemical that emits positrons because that chemical degrades, and we can put a scan in you, we can inject the chemical into you, and we can watch where does that chemical go, because the scanner can see it as it's shooting off the radioactivity. We give a specific chemical labeled with this radioactive chemical into your blood. We have now been able to radioactively label amyloid and tau. So we have available radioactive amyloid and tau. We can inject that into you, and we can use the emission of the positron with a scanner and find it and see where it went in your body. So we have amyloid and PET proteins that are radioactively labeled, and we can do images with that. We also have blood tests, our language, biochemical blood markers. So I'll go through both of those. So the amyloid PET scan was approved by Medicare in 2023. Tau protein scans have been approved in 25. You have both scans available now throughout the United States at the radiology areas of hospitals or freestanding radiology centers. So doctors can order a amyloid or tau PET scan on your brain. This is what they look like. This is a patient with mild Alzheimer's disease. This is a normal patient's brain. You recognize this from my previous sort of pictures. And what you can see is that this brain lights up like crazy with amyloid that's deposited in there. So it's not subtle. You can see it pretty easily. Same thing with tau proteins. So PET scans are available and can light up both amyloid and tau proteins. We have blood tests. You can imagine what they are. We can now measure in your blood amyloid. And we've been able to figure out, since you have amyloid in you anyway, what amyloid can we measure that can tell us something's wrong in your brain? Well, it happens to be the ratio of beta amyloid 42 to 40. Just different kinds of amyloid. You don't have to remember this part. You just want to remember that we have a blood test that can determine the amyloid in your brain that's toxic, and do you have any in your blood? The low number here of that ratio, it means you likely have amyloid, you likely have Alzheimer's. So a blood ratio of less than 0.16 indicates less blood AB42 and thus more amyloid brain plaque. Because your body is consuming amyloid beta 42 in your brain. It's the bad one. So it's less in your bloodstream, and amyloid beta 40 is more. So we do that ratio and go, aha, you have less of this in your bloodstream, meaning it's stuck in your brain. Tau protein. Tau protein goes up because we're destroying the axon and the dendrite, and it releases the television tower, the radio tower, tau proteins into your brain, and it releases it into your blood. So if we measure tau protein, an elevated level means damage. The best tau protein is number 217. You have to remember that one, because next week they might find it's 220 is the best one. But we can now, by drawing blood, measure two main things. We can measure an amyloid level and a tau level. So if you are worried you have Alzheimer's, we've got both amyloid and tau PET scans and amyloid and tau blood tests. There are also a couple other blood tests that they've played around with that I wanted to at least tell you about. Neurofilament light, which are components also of the structure like of tau. And so high level of these indicates your brain is being broken down. Now the problem is it's also very high in people with Parkinson's. and other neurologic diseases. So it's not as specific as the tau 217. Glial fibrillary acidic protein are the structural proteins in glial cells, which are not your neurons. They're the other pieces, but they react as your neurons are getting broken down. So these are two other types of tests that could be done. And what some companies have done, and that's the reason I tell you about that, is they've combined in one blood profile all of this. So you get a panel of blood tests back. So they measure this ratio, the beta amyloid ratio, they measure tau, and here they have tau 181. Here they measure neurofibrillary light, and to do the ATN test, they charge $625. Now, Medicare is paying for these now. Medicare is paying for the scans. So you're covered in good shape, and you can get blood tests and scans. Now, let's understand the usefulness of these and what this is. 2 to 3 years we've had this available, and we're still not quite sure how we can totally use these. So let me tell you our problems. We know when we do the test itself, blood-wise and brain-wise, is accurate. You don't have many false positive, false negative kind of thing. It's an accurate test. We can trust the results of those blood tests. Problem is we don't quite know how to interpret them. So it's really important to only do the blood tests and the x-rays in people you suspect have Alzheimer's disease. So if you think the person you're seeing or the person you love, you take them to see the doctor. If people don't think that they clinically have Alzheimer's disease, then these tests are very hard to interpret. So the first thing doctors are required to do is figure out, do you think they have Alzheimer's? Now, how do we do that? Well, the clinical look of an Alzheimer's patient is very different than the clinical look of somebody who has strokes causing their dementia, or somebody who has Parkinson's disease causing their dementia. Clinically, there are differences. So first step, make a clinical diagnosis if I think this person has Alzheimer's. Then the tests are best used to confirm that. The test will show you, if you think this person has Alzheimer's, that their PET scan isn't right and their blood test isn't right. That's how they're used. When I saw a presentation about this from the University of Wisconsin, I was impressed with the next slide and said, I'm going to use that because it makes sense. Okay, Minnie Mouse. Minnie Mouse has early dementia. She has clinical symptoms and signs that looks like she might have Alzheimer's. Test her. You can do scans, you can do x-rays, the PET scans, you can do blood tests, and you can say to her, we agree you have early Alzheimer's. Mickey Mouse. His mom had Alzheimer's. His brother had Alzheimer's, and he wants to know if he's going to get it. Tell me how I'm doing. Do x-rays and blood tests. No. I have no idea what the results are going to tell me. So I can't help now Mickey Mouse until he starts to get some symptoms. Minnie Mouse, I can tell. Donald Duck. He's got no family history, but he's getting older and he's really worried about how his brain's going to do. Could I use my testing on him? And hopefully you figured it out. No. We only have information right now, study-wise, doing all this testing and stuff to help Minnie Mouse. So don't go rushing to your doctor right now and go, I want these blood tests. I want these x-rays. No. You don't think your memory's good? Go talk to your doctor. All of our memories are bad. I showed you that earlier as we got older. Is it bad enough it's affecting your ADLs? That would indicate highly likely it's Alzheimer's, but I'd like to get the diagnosis earlier. The sooner I get it, the more likely I can help you. So if you're worried that your memory is getting bad, even though you haven't started losing ADLs, or you have a loved one whose memory is getting bad, even though they haven't started losing ADLs, have a doctor evaluate them. And if they think, you're right, there's an abnormality in the way their brain is functioning. And we have some very good testing to try to determine that. There are a few very standard, well-described tests called the Many Mental Status Exam or the MoCA, the Montreal Cognitive Assessment. We've got some clock drawing tests. We've got some really good sort of series tests, like take any coin you want and tell me how you're going to make $1. And you should be able to explain to me at least 8 or 10 different ways to do that. Name me fruits and vegetables. You should be able to name 8 to 10 fruits and vegetables to me in the next several minutes. So I can test your brain by asking you questions, having you draw diagrams to say your brain isn't functioning correctly. And if that's the case, and you don't have a good history of vascular disease, you don't have a history of having Parkinson's, you might have mild cognitive impairment, and now I can tell you whether or not you have Alzheimer's. Now comes the treatment side. So I've found an individual who has either mild cognitive impairment or early Alzheimer's. And what do I have available? Historically, this is what I've used. All of these replace the chemicals that your brain has lost. None of them stop the destruction caused by amyloid. And they don't work very well trying to replace the chemicals because the disease continues to progress and you need more and more, and they are all not good for you, so they create problems. So we have found these medicines to be, at best, a little bit helpful early on in the disease, at best. So all doctors, because that's all we had, will put people on these medicines. But the new treatment option is what is called disease-modifying therapy, and it's an infusion of medicines that attack amyloid in the brain. Disease-modifying therapy. We're going to change the time course of this illness and hopefully stop it so that you've lost some neurons, because that's why you're coming to see me. You've got some mild memory changes. We know the amyloid is there because we can see it on our PET scans. We can find the blood tests showing it's abnormal. Now I'm going to infuse medicine into you to kill the amyloid in your brain and stop this process. That's the logic. So there are thousands of medical articles now talking about this. And every doctor in the country is watching and seeing what's going on with this. But this is complicated and the medicines are complicated. The only people that are going to infuse this medicine into your loved one's brain is a neurologist, and they have to report all of their details to Medicare or any insurance. We're trying to track, well, is this stuff working? What's happening? How does it work? So I'm hoping to get this information out to people in the community, out to doctors who haven't heard about it. So I've given this lecture to each of the hospitals, to their physician groups. So this information is not secret, and it's not in one article or not, it's across the board in medicine now. Okay, what is this stuff It's a anti-amyloid monoclonal antibody. So you might have heard of monoclonal antibodies because they are the kind of next wave of drugs we've been using when COVID hit, because we quickly were able to develop a monoclonal antibody to COVID. And we were able to inject this into people and it would attack the COVID. It's an antibody. Like an antibody you have in your own immune system, that when something isn't right, it attacks that something isn't right and causes your immune system to destroy it. So the antibody is made in a test tube and injected into you so that then your own immune system can destroy what we're trying to make the antibody against. And we've made an antibody against the amyloid that's in your brain. So we can inject this antibody into you. It will go up to your brain. Your immune system will start to attack that amyloid in your brain and kill it off. Where exactly does it attack the amyloid in your brain? Well, this amyloid protein goes through a variety of changes before it starts to destroy your neurons, and it attacks it in different places along there, depending on which monoclonal antibody we test. And you can imagine that after the first one was found, every other research lab looking at this made a similar chemical and have been trying to get it out on the market. Right now, there are only 2 chemicals on the market: lecanemab, Lequimba, and donanemab, Kisluna. They're both very expensive drugs. You can imagine how the manufacturers who have figured this out and now gone through all the testing have spent lots and lots of money, and they're trying to recoup that. Medicare will pay for both. So they'll get the money from Medicare. Obviously, it's still all our money, but it isn't going to be out of your pocket. It's Medicare will cover these. These are only given by infusions into your blood, and they're only approved for early Alzheimer's disease. Now, they are approved for mild cognitive impairment, but if somebody has advancing Alzheimer's, it can't stop it quick enough to really benefit you. So you got to get this disease early and start these therapies early. There are side effects of these medicines, terrible side effects of these medicines. So these medicines are antibodies that get into the brain, they attach and attack the amyloid. Your body reacts to that. So now you've got this inflammatory process going on in your brain. And many people have bleeding in their brain. Now, bleeding on your arm or leg can be stopped, and in your brain, bad news. So the language is amyloid-related imaging abnormalities, because what we're doing is imaging your brain very frequently if you're taking this medicine to see, are you having any changes that would say to us you're having some very mild bleeding and we should really worry. Swelling because of the inflammation, microhemorrhages. About 1/3 of people get this. So 30% of the people getting these infusions will have changes of ARIA, headaches, confusion, visual changes are less common. Only about 3% of people had symptoms, and a very small amount, less than 1%, bleed enough. We're going to stop this drug and they're going to have a problem with their bleeding. Patients who have a genetic makeup called ApoE4 are people who are at high risk for Alzheimer's. They also, because of that genetic makeup, have a lot more amyloid stuff going on in their brain. And when you give them these infusions, they bleed more frequently than anybody else. So the neurologist has to test your genetics before they administer this. And if you're ApoE4, double positive for both of your genes, you cannot get this medicine. It's too risky. So what happens is either of these medicines, you start with a baseline MRI, not a PET scan. The PET scan we use to diagnose you, right? The PET scan we use to figure out, do you have this? But before we're going to infuse this, we want to know what your brain looks like so that we can do a repeat MRI after we've given it to you and see if we've caused any bleeding. So you get an MRI, you get an infusion. You get an MRI, you get another infusion. You get an MRI, you get another infusion. Another MRI, another infusion. So you can see we are frequently looking to be sure this is safe for you. We're not seeing if the amyloid's getting destroyed. We're looking for the complications so that we can stop it. These infusions are every couple weeks on out, and we continue to watch. So, pretty simple. It's what I told you at the very beginning. Got to understand mild cognitive impairment, dementia, ADLs, and what makes those different. Alzheimer's disease related to and caused by the plaques. Are we 100% sure on that? No. There are still people that aren't convinced that this amyloid destruction thing is actually what's doing Alzheimer's. But the vast majority of American researchers believe amyloid is our problem, and we're able to both scan for it and do blood tests for it. And if then we find it, you're not ApoE4, your brain looks good, we can infuse it in and watch and see. How long do you need infusions? How many months? We don't know yet. We've only been doing this for a few years, so we don't have all the data. That's the reason Medicare is requiring doctors to collect and send in all their data so that we can figure out. So I feel like we're on the cusp of some amazing major changes here, but we don't have all the answers. And we certainly don't know how far this can go. We don't know if we're going to be able to screen and test bigger groups of people. We don't know how to best use these infusions. And I can tell you next month there'll be a new MAB, and they'll be testing it and saying this one's better than the last one. This one causes less irritation to brains. So this whole field is rapidly changing. And what I wanted to do today was to give you the information so that you could understand the field better, and that you can then potentially, for people you love or yourself, go, maybe I need to look into this. Questions? Yes, sir.
The amyloid for in a normal.
Yeah, it's a structural. So the question was, what is amyloid for in people? It's part of the structural background of your brain and many tissues. You have amyloid in lots of tissues. It's a protein that helps form the structure of what's there. It's not a neuron, so it doesn't transmit information. And it's not an immune cell that heals things. It forms a structural protein for many organs. Yes, ma'am.
Is dietary or lifestyle that creates this situation?
So the question was, is there something, diet, lifestyle, medicine, radiation, disease, that creates the amyloid starting to destroy your brain? We don't know that. I've always said the Nobel Prize will go to the person who figures out why this amyloid that we all live with and needed turns and gets broken down and starts to destroy our neurons. Because that's the multi-million-dollar question. You know, we've been sitting on another multi-million-dollar question, a Nobel Prize, which is, why does this cell turn into a cancer cell? We don't know that. But it just seems that there's a switch of some sort, a thing that makes this thing turn. And the same thing with amyloid in the brain. We don't know why all of a sudden it starts to destroy the neurons. Yeah, somebody better figure that out. Yes, sir, you had a question.
Same,
Same thing. Why does amyloid do this?
yeah, how?
Yeah.
Is there, well, my question was same as hers, is there poor lifestyle choices that people make?
Yeah.
That contribute to these amyloid plaques going haywire.
So are there lifestyle choices people make? I'm repeating the question for everybody out there, that then create the atmosphere where your amyloid becomes bad. As best as we know today, the answer is no. And then what you're going to read in all newspapers over the next years, which you've already been reading, is that, oh, well, the newest one is the shingles vaccine seems to prevent it from happening. Well, why does that happen? So we're not sure, and you'll see little studies that pop up that say the Mediterranean diet people do better and don't get as much Alzheimer's. Or the people who take lipid lowering drugs have a higher risk of developing Alzheimer's. So it's all over the board right now. And all these tidbits keep coming out. This infusion stuff has been talked about for the last 10 years. And we've heard about it. Maybe it's going to be coming. Maybe it helps some people. But the initial tests, it destroyed people's brains. And so they had to go, wait a minute, this isn't what we want to put out on the market. So you're going to hear lots of things, because this is a terrible disease, just like you hear lots of things about cancer treatment stuff. And until it goes through the rigors of testing and figuring it out, no one wants to roll it out to people to hurt them, you know? And what I get is, if you could just roll it out and it helps me, that would be really good. But I just, people don't want to run that risk of, could it really hurt somebody? So for right now, this is available. It has a limited targeted group, and it needs to be watched very closely when we use it. Yes.
Yes. This is only effective in the early stages of MCI.
Right. Or early stages of Alzheimer's or in MCI.
And what kind of time frame are you talking?
Yeah. So if you have a diagnosis right now of mild cognitive impairment, I would be asking to see the neurologist so that the neurologist can evaluate you, do the tests they need to do, and figure out, would you be a candidate to try these medicines? Because that's the kind of person that we want to try to stop the amyloid from destroying your brain, if it is. Again, mild cognitive impairment people, only a third or so go on to get dementia. So it's a very tricky decision on when to treat them. So you want to start to see a little transition towards dementia before you're going to go through this treatment, I think. Now, you need to trust a particular neurologist to make the right decisions. And I understand. Yeah, I understand. So how do you pick a neurologist that you trust? So what I would recommend is find a neurologist who's associated with a university with large amounts of volume of people and has done a lot of stuff in this field.
What's the nearest university? UCLA?
The UCs, yeah. Now, there are neurologists who work in our community who work there and are involved in those things. So it isn't that a neurologist in Ventura County isn't connected there, but you want ones that are connected there, I think. Question? Okay.
Being tested for advanced Alzheimer's.
Yeah, so lithium has its supporters. It has been tested. But I don't think that the information is clear that lithium is a good thing. Okay? Yes, ma'am.
Would you make an approximation of the number of people, let's say in Ventura County, who might be using these new?
Yeah.
weapons?
So the question was, do I have an approximation of how many people are getting these infusions now? Is that fair? Yeah. I don't really. But, you know, this is an incredibly prevalent disease and we have a large population of seniors. So I would say the numbers are significant.
Are the HMOs, BPOs, these large organizations, do they have access to this kind of stuff?
Yes, they do. Medicare, in order to pay for it, would require that the HMO is involved in the Medicare process to do that. And most of the senior HMO plans are Medicare-based plans. Yeah, there you go. Then you would have access to it. Yes, ma'am.
So there's the of the early impairment. And there's a trickiness between too early, too late. How do you express to your neurologist, can we do more testing? Where can we go? Because right now, the only suggestion is AirSec, let's say.
Yes.
So how do you get beyond that to, what else can we do to see if it's getting closer to the Alzheimer or dementia? I mean, is there something?
So the question is, somebody who already has early dementia or early impairment, when do they cross the line and are not eligible for this? When are they start to be eligible for this? And all of those decisions are going to be made by your doctor and the neurologist. Okay. Yes, I understand. And you said, just to repeat it, that your neurologist right now is only recommending Aricept. And I would ask them about these infusions and say, when would it be appropriate to try these infusions?
Do this psychological testing is the.
Yeah, yeah. So there are lots of, the question was that you had a recommendation to do even more neurologic testing, and I would agree with that. I think more neurologic testing could help define how well is that brain functioning. But I also think the scans are important and the blood tests are important. So I would look towards getting those. Yes, sir.
Do you know why the incidences of Alzheimer's seem to be increasing?
Yeah, so the incidences of Alzheimer's and MCI are increasing, absolutely. We believe it's because we have more and more people getting to the ages where we start to see this. This isn't a disease that typically hits younger people. So you need a population where you start to see the incidence of this disease, and that population is older adults, and that population is increasing. So we're seeing more. That's what we think. We don't think it's because there are some chemicals that we don't know about yet. Yeah. You had a question, sir?
What newsletters, medical newsletters, do you recommend that we read?
So I would stick with the Alzheimer's Association because they're trying to get this information out as soon as it's out there and available. And those are the ones that I would, in general, try to have the public look at. You know, I'm looking at like the big medical journals, like the New England Journal of Medicine and those sorts of things. But to read those and understand, and they're going to be publishing things that are early, that they're studies that are looking at these things. So to get to really what could benefit the public, I would stick to what the Alzheimer's Association is looking at.
If a person is already, like me, have some of those things happen. And I can't remember things and I can't remember names of things.
Right.
At my age, which is 85. 85. Would it be too late to start?
Again, I can't tell you for sure. I think it's going to be your doctor and the neurologists who say. My gut sense, so the question was, you already have some of these symptoms and you're 85. Would it be too late for you to do this? I don't know for sure. I would recommend your doctor and a neurologist. My gut says, yes, it's too late. Yes.
And she actually, we did see our neurologist.
Uh-huh.
Here in Calabasas with CLA Health. Is that what the room is?
Absolutely. Perfect.
He did recommend all three of those tests, the PET
Mhm.
scan, the
Yep.
MRI, and the
Yep.
blood test.
Good.
Just got completed
All done.
last week. So
Good.
we're waiting to hear from
Perfect. So you're going to figure out, she's kind of the Minnie Mouse. She has symptoms. You're getting the test to verify whether or not. Then the real question is she early enough in this that they can help her with these infusions? How risky are these infusions to her at her age? And whatever other diseases she may have, but you're in the process and you're doing the right thing.
Good. He did start.
Yes. Yeah, because that's all we have. I mean, that's all we have. PET scans. She should have PET scans and blood tests. PET tau and PET amyloid scans. Yes, sir.
When I about a year ago, I had a checkup. My doctor ordered a number of tests and he says, okay, you're in amazingly good health. So as the years go by, are there specific types of tests that I should have, or just go to my doctor and say, okay, it's been 2 years or something since I've had a complete physical, or exactly what do I ask for?
So with the idea of memory disturbance, not all your other blood tests and all your other diseases, the question is, what do you ask for? So I would ask the doctor if you could test your memory. Test my memory. Let's see how I'm doing with my memory, because like all older people, you start to notice some little pieces. So they should be able to sit with you and administer questionnaires to test your memory. That's what you want to get.
But the test is the one that you heard.
Yep, yep.
Which is what determined.
You remember her MoCA score? 10 out of 30. Yeah. So as I said earlier, I suspect she's not going to be eligible. The MoCAs that are best are like 20 to 25. So Alzheimer's MoCA testing, 30 is the right answer for all of us who have normal brains. 20 to 25 is the early process of it. 10 is later on down the disease. I can't tell you for sure you're on the right track with what you're doing. Yes, sir.
Doctor with UCLA Health, neurologist, you would recommend, you don't have names or a list?
No, not going to go there.
And this time scale, are we talking about a time scale of weeks, months, years?
For what?
If you think you have it and you can't even get a doctor until July,
Oh.
because
So this is a year after year process. This isn't weeks. This is years. So it takes 15 years for this amyloid to start to destroy your brain well. So you want to catch it in the first few years as best you can.
not the first few weeks or months.
You don't have to.
Is a patient with APOE4 definitely not a good candidate, meaning the risks are too great for potential rewards for any of the current infusion therapies? Also, any truth in any of the theories that consuming certain types of honey help to stop Alzheimer's?
So the question was, does honey do anything good or bad? And nobody knows, and everybody's trying to find something. So I'd say don't put your money into honey or out of honey. The better question was, if you're ApoE4 positive in both alleles, Right now, you're not eligible to get these infusions. What I can tell you also is there's a lot of still things happening in this field. And there are growing amounts of testing to try to determine how to follow, how to make these infusions work well and yet cut them back dose-wise or spread them out so that other people could become more eligible. So I today would say ApoE4 rules you out, but I can't tell you what's coming next year.
So I know that we didn't have time to get to all of the questions, and I still have some online. So for people that are trying to get more questions answered, where do you recommend it?
I would recommend they talk to their own personal doctor. And if that personal doctor isn't aware, ask for referral to a neurologist in the community. Those are the two places that you're going to get your best, most information. Thank you guys for being here.
Remember the report